Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and today we're going to be talking about bundle branch blocks. Something pretty basic in ECG interpretation, but important for us to have a good grasp of. A bundle branch is an interruption of the normal conduction system, leading to aberrant conduction and an abnormal QRS morphology. Under normal circumstances, the SA node generates an impulse which goes to the AV node. Conduction splits into the right and left bundle branches. The left bundle branch is composed of anterior and posterior branches. A bundle branch block can occur in any of those three branches, the right bundle or the two pieces of the left bundle. Let's start with the right bundle branch block. Normally, the right bundle depolarizes the right ventricle. In a right bundle branch block, the right bundle doesn't activate. The right ventricle instead is depolarized by spread of the impulse from the left bundle through the left ventricle and then into the right ventricle. This aberrant electrical spread creates an aberrant QRS morphology. What we see on the ECG is different than normal because of the delay in conduction. The depolarization vector produces delayed R waves in leads V1 to 3 and a delayed S wave in the lateral leads. Of course, we're going to have images in the show notes, so you're going to pop over, you're going to want to look at all of those images to kind of match with what we're talking about. The criteria for a right bundle branch block is a rhythm that is supraventricular in origin, has a QRS duration greater than 110 milliseconds, a terminal R wave in lead V1 giving an RSR prime morphology, otherwise known as the rabbit ears, a wide terminal S wave in leads 1, AVL, V5, and 6, so your lateral leads, and the axis is going to be normal. You can also have a partial right bundle branch block. That's defined as morphology with a QRS less than 100 milliseconds, but you can still see things like that RSR prime in V1. And this can be a normal variant in a lot of people. It's seen in up to 10% of the general population. As an acute change, it might signify right heart strain in something like a pulmonary embolism. The left bundle branch block is a little bit more complicated because the left bundle is composed of two fascicles, the left anterior and the left posterior fascicle. Normally, a left bundle depolarizes the left ventricle. In a left bundle branch block, the left bundle doesn't activate. The left ventricle is then instead depolarized by spread of the impulse from a right bundle branch through the right ventricle and then into the left ventricle. That delay in the spread of the impulse, because it's being conducted from the RV all the way across to the LV, creates the aberrant QRS morphology that we see in the left bundle branch block. Additionally, you can have single blockages of either the anterior or the posterior fascicle. Criteria for a left bundle branch block is a rhythm that is supraventricular in origin, a QRS duration of greater than 120 milliseconds. In leads V1 and V2, you're going to either see a big Q, big S, or a little r, big S morphology. And then you're going to have broad, dominant, monomorphic R waves in leads 1, AVL, V5, and V6, again, those lateral leads. From there, let's get into the individual fascicle blocks. The left anterior fascicular block, or LAFB, or left anterior hemiblock, results in LV depolarization via the left posterior fascicle only. This is going to produce small R waves in 2, 3, and AVF, and a tall R wave in the left-sided leads with a deep S wave in the inferior leads. The criteria for a left anterior fascicular block is a left axis deviation, so the QRS is up in 1, down in 2 in AVF, a slight prolongation of the QRS complex, but it's going to be less than 120 milliseconds, small Q waves and large R waves in leads 1 and AVL, and small R waves and large S waves in leads 2, 3, and AVF. We mentioned that in a left anterior fascicular block, you're going to have a left axis deviation. There are other things that cause a left axis deviation as well, including a left bundle branch block, LV hypertrophy, inferior MI, ventricular ectopy, a paced rhythm, and sometimes in WPW. In the left posterior fascicular block, or the left posterior hemiblock, you have blockage of that left posterior fascicle, and so all of the LV depolarization occurs through the left anterior fascicle. An isolated left posterior fascicular block is much less common than an isolated left anterior fascicular block. And when you look at the ECG with a left posterior fascicular block, what you're going to see is a right axis deviation, so QRS is up in 3 and AVF and down in 1. A slight prolongation of that QRS complex, but again, less than 120 milliseconds. A little q big R complexes in 2, 3, and AVF, little r, big S complexes in leads 1 and AVL. There should be no evidence of RV hypertrophy and no evidence of another cause of right axis deviation, which takes us to the causes of right axis deviation. So obviously the left posterior fascicular block, an old lateral wall myocardial infarction, acute pulmonary hypertension, again like you see in a pulmonary embolism, chronic pulmonary hypertension, sodium channel blocking drugs, hyperkalemia, RV hypertrophy, and misplaced leads. Again, this is all pretty visual, so you really need to match the audio with all of the images that we've got on the website. And I'll link to some other great posts from Life in the Fast Lane, as well as some prior posts on Rebel EM looking at bundle branch blocks. That's all for the Rebel Core Content Podcast this week. We'll be back in 2 more weeks on our cast. In the meantime, don't forget to pop on over to the site and check out all the great posts from our wonderful faculty. And until next time, stay safe.